You've been dispatched to a 70-year-old male who has collapsed.
So first thing, just considering safety of the scene, considering if there's good working space around my patient, any immediate hazards such as bystanders or pets that could interfere with a resus. I'm also considering environmental hazards as well. Do we have a good working space, and do we have good lighting around our patient, and what's the temperature like outside? Also considering access and egress from the scene and our distance from a closest tertiary hospital. So we're wearing the correct PPE, we've got my gloves, glasses and boots, and I'm happy to approach the scene. Are you happy? So, hi sir, can you hear me? Hi sir, it's the ambulance, can you hear me? Can you open your eyes if you can hear me? I'm not a response to voice, touch or breathe. Just going to use a head tilt chin lift just to look in the airway here. And I'm not seeing any obvious obstructions such as blood or vomit. So I'm just going to expose my patient's chest. And I'm going to look, listen and feel for breathing for 10 seconds. Nirvana, can you please put the monitor onto manual mode for me please? And just get the defib pads on. Okay, so our patient isn't breathing. I'm going to start continuous compressions. If you're able to discharge the monitor, call for backup. Just get ready to shock for me please. I'm just going to step off. So analyzing, stand clear, shock, that's VF. Awesome. So that shock was delivered at 20 seconds. So I'm just going to keep going with continuous compressions for the moment while you get our size 4 LMA set up for me please. And we're going to reanalyze at 2 minutes 20. And if you could also make sure that the oxygen is on at 15 litres per minute, that'd be fantastic. And then we'll get started on a ratio of 30 to 2 when the airway's set up. So I'm looking around my patient for any indications as to his collapse. If there's any obvious blood loss or trauma, which I am going to do a trauma sweep later on to help establish that. Also looking for any bystanders. There is no one around at this point, but I would be asking regarding medical history, what medications our patient is on, and the event prior leading up to his collapse this morning. So if we just want to test that LMA, I'll count it down from 3 and we'll give 2 breaths, okay? So 3, 2, 1. Chest rise, fantastic. So I'm just going to keep going with continuous compressions while you secure that LMA. Can you please just also make sure that the capnography is attached as well? Perfect. So I'm aiming for a rate of compressions between 100 and 150 at the moment. And on the next cycle, Nirvana, we are going to swap roles, okay?
Yeah.
Are you going to be happy doing over the head compressions?
Yeah.
Fantastic.
Bring you down. 3, 2, 1.
Still getting good chest rise and good chest rise, perfect. Sweet. So we're going to be reanalyzing in 30 seconds. So same thing, what I will get you to do is press the charge button for me please. And then I'm going to jump off the chest. Yeah, press charge for me. Yeah, I'm going to jump off the chest and analyze the rhythm and get ready to shock, okay? So jumping off, that's still VF. Can you shock for me please? And back on compression. So that shock was delivered at 2 minutes 20. Awesome. So are you happy to also do ventilations with your CPR?
Yeah.
Perfect. Just at a ratio of 30 to 2. I'm going to do a quick trauma sweep of my patient here. I'm looking for any obvious blood loss, and we will be reanalyzing at 4 minutes 20. So I'm not seeing any obvious blood loss or trauma at this point on my gloves, and I'm not feeling any dislocations or fractures. So considering my H's and T's, we're treating hypoxia as a probable cause with high flow oxygen running at 15 litres per minute. Also considering hypervolemia and trauma as well as potential causes, but I wasn't seeing any of that in my quick trauma sweep. However, we can't rule out hypervolemia from internal causes. So thrombus, toxins and tamponade, really hard to ascertain at this point without a patient history. Also considering hydrogen ions and hyperkalemia, but this is also really hard to ascertain pre-hospitally, and we would need a 12-lead ECG to really help confirm that one. Those are great compressions they're doing there, Nirvana, great depth and good recoil. Also considering hypothermia, but I don't think this is a probable cause. We don't know how long our patient has actually been down for. On the next ventilations, I'm going to auscultate, okay?
5, 4, 3, 2, 1.
Awesome. So we're getting good equal bilateral chest rise, so happy to rule out tension pneumothorax as a probable cause at this point. We've got 30 seconds left on the monitor, Nirvana. How are you feeling at the moment?
Thanks.
Okay, perfect. As I said, really good depth and recoil with those compressions. Awesome. So I'm going to come around So we will be reanalyzing at 6 minutes 20, okay? And we'll just keep going at a ratio of 30 to 2. Are you able to count my